This presentation is an introductory training resource for new cochlear implant champions. The contents of what we are going to cover is shown on this slide. Firstly, we'll cover what the scheme is, what a cochlear implant is, and the NICE criteria for cochlear implantation, why we need the scheme, and how we can help. Moving on to the role of the champion and mentor, and finishing up with case studies and practical advice on moving forward, including counselling of possible candidates. So what is the Cochlear Implant Champion scheme? So firstly, the scheme was launched in 2019 as a joint initiative between the BCIG and the BAA. The scheme came about following widening of the criteria, but poor awareness still and referral rates of this. The purpose of the scheme is to improve referral rates for cochlear implantation in the UK from both independent and NHS services. Our aim is to have a cochlear implant champion within both adults and paediatrics in every audiology department within the UK and every cochlear implant programme to have a named cochlear implant mentor. So what is a cochlear implant? A cochlear implant is an electronic device which may be suitable for children and adults who do not receive enough benefit from conventional hearing aids. Conventional hearing aids work by making sounds louder. A cochlear implant is different because sounds are turned into tiny electrical pulses which are sent directly to the nerve of hearing. The implant can therefore bypass some of the inner ear structures which are not working. A cochlear implant has several different parts, some of which are internal, cannot be seen, and some of which are external and are worn on the body. The external components are those that are worn on the ear or head. These look similar to a hearing aid, but actually work quite differently. There are two main types of external device. The ear level device, which is similar to a behind the ear hearing aid, which consists of a microphone here, and a sound processor, which is this part, the external transmitter coil here, and the cable that connects them together. There's a second type of processor, which is an off-the-ear option, which attaches by magnet to the internal package only. All of the components of the behind the ear option are encased within one unit with the off-the-ear option here. There are retention options for both types of devices, and this will be discussed with patients. Many centres insist that ear molds are worn as an anchor for children, or retention clips are used by adults, particularly if they're wearing the off-the-ear option. Not all centres provide patient choice, so it's beneficial to see what your local centre offers. Please do contact your mentor. For small children, the battery unit can be worn clipped to the clothes, leaving the microphone and the processor behind the ear, making it lighter and more usable. The microphone picks up incoming sounds and changes them into electrical signals. The processor contains the batteries which power the entire cochlear implant, so there's no internal battery that needs to be changed, but the external batteries do need to be charged or changed if using disposable. During programming sessions, the processor will have been carefully set to make the signal just right for the individual. The signal is then sent to the external transmitter coil and magnet, and the signal passes through the skin using radio waves to meet the internal parts of the implant. The internal parts are the parts of the device implanted by the surgeon during the cochlear implant operation. These include the internal receiver stimulator package with the internal magnet. This lies under the skin behind the ear, and it can be felt as a lump if touched gently. The receiver stimulator package picks up the radio signal from the outside transmitter coil. And from here, the signal is taken via a thin wire to the cochlea. So down here. The end of the wire has something called the electrode array, and this is threaded into the cochlea by the surgeon. Because the shape of the cochlea is a spiral, like a tiny snail shell, inserting the electrode array requires considerable delicacy and skill. On the electrode array itself, there are several points at which the electrical signals are delivered. These are called electrodes. The different electrodes take a part of the signal depending on the particular electrode is tuned for high or low pitches, so that different sounds can stimulate different areas and regions of the cochlea. The signal from the electrodes activates the nerve of hearing, which then takes the message along the usual pathway to the brain. At this stage, the signal may be interpreted by the brain as a sound, but experience and practice will help people to begin to tell the difference between some of the sounds the implant is giving them. Obviously, this takes a lot of work, and this is where the rehabilitation team will be able to assist and support. And the idea is to make the whole experience interesting, engaging, and with children fun. So who is a cochlear implant suitable for? In 2019, NICE changed the criteria to widen those applicable for a cochlear implant. The criteria are that the unaided PTA thresholds at 2 or more frequencies at 500, 1, 2, 3, or 4 kilohertz at equal to or greater than 80 decibels. And the aided AB score less than 50% in adult and postlingual pediatrics. When considering younger children, the criteria depends on an assessment of their speech, language, and listening skills. Children born with a profound hearing loss and those who develop a profound loss from meningitis are automatically considered for implantation, subject to other factors. So why do we need the scheme? Thankfully, the referral guidelines have widened, as I mentioned previously. The benefits from cochlear implant are widely demonstrated, and yet the number of individuals with a cochlear implant remains very low. It's been demonstrated that cochlear implant recipients experience improvements in speech perception, educational and employment opportunities, and general quality of life. Cochlear implants have been shown to be cost effective. However, use of cochlear implants in eligible adults is as low as 5% globally and predicted to be as low as 7% in the UK. Duration of hearing loss before cochlear implant is increasing over time. There is a low awareness of cochlear implant as a treatment option, and there is low awareness of cochlear implant candidacy criteria. There are many references on this page that can all be found at the end of the presentation. So these are all well-known global facts, and this led to a UK-wide audit, which I'll cover now. So CIRCA is the Cochlear Implant Referral Criteria Audit, and this was a UK nationwide study that was a retrospective audit of patients seen in NHS secondary care ENT and audiology units. It was carried out between July and December 2021. And it was found that only 36% of patients had a documented discussion informing them of their eligibility. So by that, I mean that in their journal entry, whether that be on Audit-Base, Practice Navigator, or a different service that's used, that was actually documented only to have that discussion in 36% of time. And only 9% of eligible patients were actually referred. In addition, it was found that patients from least deprived locations were more likely to be referred and more likely to have that discussion. Patients from a minority ethnic background were less likely to be discussed than white patients. And it was less likely as a older adult to or male to also be referred. It is more likely to get a referral if profound hearing loss. So by that I mean well within the criteria through audiogram. Also, if the audiology department is joint with the implant centre, and also more likely to be referred if the department has a cochlear implant champion. So I think this just really highlights how important your role is. So how can we help? We can help to improve communication between referring and implant teams. By this, contact your local mentor, discuss cases that you were unsure about, ask for updates on those that you were referred. Promote shared care between teams to ensure patients have a smooth and timely transition from hearing aid to cochlear implant, obviously, if they want it. Audit. Understand the training needs and drive changes in clinical practice, and help and advice on performing the audit-based audit can be found both on the BCIG and the BAA web pages. If you're stuck, please ask. Training focuses on candidacy and referral. So train others, not only students, but also mature colleagues. Discuss cases at team meetings, learn from each other, and provide that peer support. And then enable colleagues to develop and re-evaluate their practice. This has to be a national change, and it can only work if driven by referring audiologists, such as you. So what's the role of the champion? The role is to train, support, and empower staff in your team to counsel patients, clients, and their families about cochlear implants. Cascade training. You get the support from the committee and other champions and your mentor, and you then teach, educate others in your team. Be the go-to for colleagues who are unsure a cochlear implant referral is appropriate, and therefore ensuring all eligible patients, clients, and their families are offered informed choice and shared decision-making when considering a cochlear implant referral. In addition to audit the quality and quantity of cochlear implant referral counselling taking place in your service and monitor referrals. The scheme is growing. In 2020, there were 83 registered champions. In 2023, there were 130. So the role of the mentor. The mentor is a role taken on by an experienced cochlear implant clinician who works within a cochlear implant team. Their role is to support the champions, who will each support their own team. The champions and mentor form a link between the implant and referral services. The mentor should contact their local referring champions and arrange observation sessions, advise on referrals, resources such as posters, and any user groups as applicable. Now, implant counselling can be very difficult as there is insufficient focus on candidacy and referral counselling in education during formal qualifications. And what theory students are provided with is then not consolidated during placement. Skills are not supported, developed among newly qualified audiologists, and there's a great fear of being wrong, which is generally driven by the lack of knowledge and support. In addition, there is no motivation, no encouragement to discuss implants. It is not the norm, not audited, not expected. So many people believe it is not my area. I don't do implants. But implants are everyone's area. You don't have to be an expert to advise patients that there are additional options available to them. You don't have to guarantee or promise anything, but you can be well informed in order to ensure that the patient has their own ability to be well informed. Cochlear implants should be discussed throughout a patient's journey, especially if there is a progressive loss. So we're going to move on to some case studies. These are mainly adult focused as it is easier to clearly show the outcomes in the adult population. Case study 1 is a 69-year-old female with an unknown etiology, a gradual hearing loss since her mid-30s. She generally managed very well one-to-one, but was struggling in noise and was unable, when unable to lip read, she also really struggled. She was reviewed by our team for many years on our review suitability list. And many years she was outside of criteria. Preoperative scores can be seen on the slide, where you can see that she significantly struggles when there is no context, such as when doing AB words. You can also see that she struggles greatly with female compared to male BKB, which also indicates a difficulty with the higher pitches. From her audiogram, you can see a steeply sloping high-frequency sensorineural hearing loss, and her aided responses from conventional hearing aids were poor in the high frequencies, given the severity of loss. So she was not aided into the speech banana that we would say. This lady had a right cochlear implant and she did very well from day one, hearing sounds. At her 1 week review, a significant improvement can be seen in speech scores. And she reported being able to hear her daughter better and being able to follow a conversation in the car, which is something she previously was unable to do. At 3 months review, she reported hearing her daughter and husband very well and was able to hear the TV. As you can see, speech scores have improved and her aided are all within the expected range across all frequencies. So giving back the high pitch aided responses that she was unable to obtain from her hearing aid. I'm sure she'll continue to improve by the time she is reassessed at 12 months. So I've just put here in the box, so keep a close eye on the steeply sloping losses because a small change in thresholds can have a huge impact on speech detection. Case study 2 is from an older gentleman who was 90 years young when he was referred. He reported a sudden hearing loss in the right and a gradual progressive hearing loss in the left ear. He had worn left hearing aid for about 30 years, but over the years was struggling more and more with speech discrimination. He remained independent, but was becoming more and more isolated with time. His preoperative speech test showed his dependence on lip reading with a BKB male score of 2% and AB score of 21% phonemes. So he received a left cochlear implant. Given the duration of the dead ear on the right, that was not a possibility. At switch on, he heard speech immediately. He was able to follow conversation with no typing. At 1 week review, he reported that the cochlear implant had exceeded his expectations. He'd been to the cinema on his own, and he had followed the film without subtitles very well. He feels more confident to talk to people and start conversation when out walking, and he feels safer within his own home as he can hear environmental sounds. Speech scores showed a great improvement at just 1 week, from 2% to 58% BKB, and we've only just got started as he's not even reached 3 months. And I've just placed here in the box, it's all about health and not age. So do refer the older population. For case study 3, we have a gentleman with congenital hearing loss, referred at 45 years old with a history of no hearing progression. He wore hearing aids as a child, but due to working in a factory, he became a non-hearing aid wearer due to the noise and had not worn hearing aids for 25 years. This gentleman uses both BSL and spoken language, using speech with his family and BSL with some childhood friends. As part of his assessment, we ensured he had a hearing aid trial to ascertain commitment and benefit. The hearing aids were consistently worn for a period of 3 months, with the aided levels as shown above. Them here. Puny was recorded at 21%, and his main aim was to be able to lip read better. Oops. After extensive counselling, he received a right cochlear implant. At switch on, he felt dizziness and some puffs of air, with sound only on a few electrodes. He reports that the first week was very difficult for him. However, he remained committed and engaged in rehabilitation. He heard environmental sounds around him during the first week and gradually became accustomed to a noisy world. At his 12-month review, he felt that most of his improvement had actually been made in the previous 3 months, and he reported a great improvement in lip reading and stated that he had wished he'd had the cochlear implant 10 years previous. He was unfortunately made redundant, but has set up his own limited company. His aided results are seen on the audiogram, and the CUNY results were 45%. The benefit achieved is not represented by speech testing, but can be seen through the quality of life questionnaires. So do please consider congenital patients, but also please be respectful, as they may have strong opinions against. On this slide, you can see 3 different audiograms of patients who have all received a cochlear implant. Some of these may not be classed as a classic candidate for a cochlear implant. And I've put these here just because if in any doubt, anything unusual, talk to your mentor. We've got a low frequency sensorineural hearing loss, high frequency hearing loss, and the third one here is actually on paper outside of criteria, but further assessment revealed that this person had autotuneuropathy. Okay, so where do you start? Remember, it's a team approach. Support each other. Experienced staff should support the new, less qualified staff. Adopt a no-blame culture and get all staff on board. Patients need a consistent message. Use posters and leaflets to empower patients to ask about implants. Patients are part of your team. And also, not to forget, your mentor from your local cochlear implant service is also part of your team. So all cochlear implant champions should receive protected admin time each week to work on the cochlear implant champion actions. The next 2 slides give some suggestions on what you could do within this time, such as becoming familiar with the BAA champions page, web page, and all the resources within that. Gathering feedback from your team to explore the barriers. Gathering resources so it is available when needed. Arrange manufacturer referral training. All of the cochlear implant manufacturers will be happy to deliver either face-to-face or remote training. Create or review a cochlear implant referral form, ensuring that this includes the aspects shown. Your local cochlear implant centre may have a standard referral form, and contact your mentor and ensure that you have that pathway of communication. Arrange observations if you can obtain the study leave. Observing MDTs, assessments, surgery, switch-ons can all be extremely beneficial. Run the crystal report training. And should you require training on this, that can be obtained from the BAA Champion webpage. Okay, so there's an extensive list of references here for further reading, but I also wanted to mention the importance of engaging with the manufacturers. Their webpages are shown on the slide, and they have many valuable resources. And as I've said before, don't forget to visit the Cochlear Implant Champions webpage for previous presentations and resources. And if you ever get stuck, please do contact us. Thank you.